We'll start in another 5 minutes. Just give.
Okay, sir.
Hello, can you hear me?
Yes, sir, we can hear you.
Hemanth sir, shall we start?
Yeah, am I visible?
Yes, sir, we can see you.
Oh, okay, fine.
Clear.
So, screen is fine.
Yes,
You
sir,
have to make it
fine.
full screen.
Full screen now. Oh, okay, fine.
Yeah, perfect.
Beam, we are ready.
So we can start in next 10 seconds, sir.
Okay, fine. Good evening, students. Today we are here to discuss the medical oncology recall session of the NEET SS 2022. This is Dr. Hemanth, and along with me is Dr. Vijay. Few basic things that one probably can notice from the NEET SS 2022. Pertaining to oncology, you did not have many questions. Probably the subject felt probably to be sidelined. There is overlap with other systems. Hemato-oncology was the majority of the portion. You did not have much of solid tumors that were involved. And this is obviously expected considering the fact that they have to cover the entire medicine syllabus. A lot of questions being on genetic syndromes that were seen. More importantly, the questions were factual. This is NEET SS and not NEET PG. And probably I would have expected more testing of clinical scenarios. But then understanding the fact that there are other allied branches like radiation oncology trying to look for medical oncology, anesthesia, everything answering nearly the same paper. That was probably the reason why the questions were factual. But going with the feedback, I think they might have a tendency to change the paper the next time. And more importantly, these were basics, especially in oncology and hemato-oncology. The questions were basics. They asked the most basic stuff that is associated with these malignancies. And considering that, even though these are few questions, but then these can actually make or break the results. So we will be discussing few questions that were there. Yes, there was more of hemato-oncology, which probably would have been discussed in hematology session as well, but probably we'll give our own perspective for the same, and what few solid questions that were included also will be discussed. So the image is characteristic of what? Hodgkin lymphoma, ATLL, mantle cell lymphoma, follicular lymphoma. The options could have been probably something different, but this is a basic image. This is straightforward from Harrison or your Robbins. What you see is the classic RS cell. RS cell, the classic one, is a large cell with binucleate or bilobed central nucleus, which looks like owl's eye, and hence it's called an owl's eye appearance. Each with prominent eosinophilic-like inclusion nucleoli. So this is the classic RS cell that is seen. You have other variants like mononuclear variant. The mononuclear variant is also known as Hodgkin cell, where you have only one single nucleoli that is seen. Then you've got what is called lacunar variant, where the cytoplasm is actually lucent. It is clear and hence probably appears like a ghost cell with a large central nucleus. So this is more often seen in the nodular sclerosis subtype. Then you have got what is called lymphohistiocytic variant. Lymphohistiocytic variant is where you have what is called these kind of cells called the popcorn cells, where there is extensive folding, because of which it looks like a popcorn cell. This is classically seen in NLPHL. A classical Hodgkin lymphoma, the immunohistochemistry is CD15 positive, CD30 positive, CD20 is negative, and CD45 negative. This is in classical Hodgkin lymphoma, not in NLPHL. Whoever is watching, answer this question: that what is the cell of origin for Hodgkin lymphoma? And if it is a B cell in origin, why the CD20 is negative? And probably what other immunohistochemistry can be used for proving that this could be of a B cell origin? So you can answer in the comments and we can have the discussion later on as well. So the answer for this was Hodgkin lymphoma, and a classic RS cell was shown. So going ahead with the next exams, remember simple basic images from Harrison's Hemat, non-Hemat can be asked for the exam. So compile the questions, compile these images, and these are something which one should not miss. Which of the following drugs is not used in Hodgkin lymphoma? This is a straightforward question. You got adriamycin, bleomycin, vinblastine, and daratumumab. Your standard regimen being ABVD, which is the most common regimen, which probably you would have heard from your UG days as well, and probably during MD medicine days. The answer here is daratumumab. So adriamycin, bleomycin, vinblastine, and dacarbazine is the actual answer. Daratumumab is an anti-CD38 antibody, which is used in multiple myeloma. So what are the other drugs that are used in Hodgkin lymphoma? You can comment in the comment section. And probably what is the newer anti-CD38 antibody which is approved for treatment in multiple myeloma? So again, they stuck to Hodgkin lymphoma, which is one of the very common malignancies that one need to know whatever it is. And basic aspects after the Reed-Sternberg cell, the next being what is the basic chemotherapy drug regimen that is used, and the odd one out in that. Going ahead, CLL was another hemat malignancy that was discussed. A 74-year-old gentleman on evaluation was found to have a CPC of 11.5, counts of 90,000, and plated 4.5 lakh. On examination, he had splenomegaly and generalized lymphadenopathy. Further evaluation, a diagnosis of CLL was made. What stage does this patient fit in according to the RAI staging system? So you have stage 0, 1, 2, 3. This is one malignancy where you have stage 0. So RAI staging is named after Dr. Kanti Rai, who is of Indian origin. So you have stage 0 where you have only lymphocytosis in blood or bone marrow. Stage 1, you have lymphocytosis with enlarged lymph nodes. Stage 2 is where you have organomegaly, associated with lymphocytosis with or without lymphadenopathy. So you need to have organomegaly. It is not only lymphadenopathy, right? Fine. Stage 3 is lymphocytosis with anemia. So your hematopoietic lines are now getting affected. So anemia with or without enlarged liver, spleen, or lymph nodes. And stage 4 being lymphocytosis with thrombocytopenia, the platelet count of less than 1 lakh. So you have 0 to 4. So based on the question, this patient fits into the stage 2 where there is lymphocytosis and enlarged liver or spleen, but the hemoglobin is 11.5 and platelet is 4.5 lakh, and hence the stage is stage 2. The other staging system, that is Binet, is rarely used, but however you have the staging as ABC and not as 1, 2, 3. So here stage A is 2 or less lymphoid bearing areas enlarged. Stage B is 3 or more lymphoid bearing areas enlarged. And stage C is presence of anemia and thrombocytopenia. Now you might be thinking that previously we discussed hepatosplenomegaly, and here there are only lymphoid bearing areas discussed. Remember, these are lymphoid bearing areas and just not lymph node. So the 5 possible areas include cervical, axillary, inguinofemoral, spleen, and liver, and these are categorized again as the lymph node regions are categorized right and left. So you have right cervical, left cervical, right axillary, left axillary, inguinofemoral in the same way, and spleen and liver. So based on that, your stage B comes into play. So RAI staging is what is most commonly used, not Binet in the clinical setting. Next, going to AML. AML is a very important malignancy. Probably all oncologists and hemato-oncologists probably would have got excited by AML and have taken hematology, other being Hodgkin lymphoma. So AML is something that cannot be left behind, and this has been discussed in our test series and QRP sessions as well. So what is the bad prognosis in AML? We always end up reading about the good prognostic factors. So question is simple. You can probably eliminate what is a good prognostic factor. But as a matter of fact, you need to know that a complex karyotype is the worst prognosis in AML. So you have got translocation 821, NPM1, and biallelic mutated SEPA. So if you look here, the biallelic mutated SEPA has been kind of redefined based as BZP mutated SEPA. I'm not going to details as what exactly it is. Now, this is the newer risk categorization. The previous was 2017 ELN, where you had biallelic mutated SEPA. Mutated NPM1 alone is mentioned there, which probably you can take it as a FLT3 negative. So that becomes a good risk. The other good risk includes translocation 821 and inversion 16. Remember, your APML doesn't fit into this classification. It is not rated in the same way, and hence it doesn't have this risk stratification. So translocation 821, inversion 16, mutated NPM without FLT3, and biallelic mutated SEPA, or in current you have got BZP mutated SEPA. So this forms the favorable category. So in the adverse category, you have a lot of mutation that probably you might have, you think that you might have to remember. No, of this, something that you need to remember is translocation 922. BCR-ABL in AML is an adverse prognostic factor. Inversion 3 is associated with poor prognosis. Monosomy 7 or deletion 7 and deletion 17p and deletion 5 are again adverse. The worst of the lot is the complex karyotype, and hence in case you have a new patient with AML, the tendency is usually to check for all the mutations like NPM1, FLT3, translocation 821 and inversion 16 by PCR techniques. But more importantly, assessing your karyotype or doing a conventional cytogenetics is also extremely important, because in case you have even the above risk group with the complex karyotype, it is associated with a very poor prognosis. So this is the ELN 2022 classification. One important point to be remembered here in the newer classification is previously a lot of questions used to be asked between NPM and FLT3. Now, previously FLT3 positive, that is wild type NPM1 with FLT3 was in adverse prognostic factor. Now, any FLT3 positivity is associated with an intermediate prognosis. And also the allelic ratio, which was previously being discussed on FLT3, is now not valid. So FLT3 positivity makes it intermediate risk. FLT3 negative and NPM1 positive makes it favorable. There is no FLT3 adverse prognostic factor right now. Another question on AML, best prognosis in AML. You have got M0, 1, 2, 3. You can probably even keep 4, 5, 7, whatever an option. The best prognosis is always APML, that is M3. AML M3 is also known as acute promyelocytic leukemia, which again brings a lot of interest and enthusiasm in people who treat these malignancies, simply because of this graph. APML and probably all other AML based on FAB classification M0 to M7, you can put in the other basket. APML is always associated with a much better prognosis. So you can see here a long-term survival of APML is almost around 85%, whereas your classical AML is somewhere between 30 to 40%. So APML is always associated with better prognosis, and APML is also known as AML M3. A patient with Hodgkin lymphoma post 2 cycles of ABVD, reassessment PET CT is done. What score or criteria is used to assess the response? You had options like Lugano, Diovel, Ann Arbor with Cotswold modification. Probably I have added RECIST to this. Now, RECIST is something that is used in solid tumors. Ann Arbor staging of Hodgkin lymphoma was the old classification. Then you had Cotswold's modification. And the latest is what is called Lugano's classification. Lugano's classification of Ann Arbor with Cotswold modification, which came, I think, in 2014 or 16, where your PET CT becomes an important part in staging, and something like A symptoms and B symptoms. We know that B symptoms, especially in Hodgkin's, you have fever, night sweats, and weight loss. Now, this is not included for a NHL staging. So that was included in Lugano. And there are a few other finer criteria which I'm not going to discuss here. But what score is used? Now, this is what is called a Diovel score. So if you see, this was a patient of mine, 20-year-old young guy who had actually initially presented with nephrotic syndrome. Biopsy was not done. He had responded to steroids, and when steroids were being tapered, he started developing cervical lymphadenopathy. So you can see mediastinal and cervical lymph node mass here. So this was the upfront PET CT. He received 2 cycles of ABVD, and you can see that the mediastinal nodes have completely disappeared. There are few cervical nodes here. These were reactive nodes, but you have probably few cervical nodes here which appear intense. This is also actually reactive nodes. The upper chain is what we are probably going to see. His report was given as like this: mediastinal nodes, Diovel score of 1, and cervical nodes, Diovel score of 2. Now, what exactly is Diovel score? This is a visual interpretation score. So when you see this image, you start comparing the FDG uptake that is seen in the mediastinal pool, liver. These are the 2 main sites. So anything less than probably mediastinal pool. So you have 1 as no uptake. So in case you can see here, say this patient had a previous axillary node and now it's not showing uptake, it becomes a D score of 1. In case you have a lesion, say cervical lesion here, but the uptake is less than the mediastinal pool or the mediastinum image, so this becomes a D score of 2. So if you look at here, compared to what is seen here, this probably appears slightly fainter, and hence it was D score 2. D score 3 is when the uptake is more than the mediastinum but less than the liver. D score 4 is uptake that is more than the liver at any site. So here, imaging wise, you can make out that more than the liver uptake, you have the uptake here. 5 is when there is a very significant dark uptake, and this probably represents new sites of disease. There is a category called X, where probably new areas of FDG uptake unlikely to be related to lymphoma, maybe like reactive lymph node that I showed in the previous picture. This patient had bilateral reactive nodes and even tonsillar uptake here. So that is called X. So this is a visual interpretation score. You see the PET image, and based on the uptake compared to mediastinum and liver, you grade this. Now, why is this important? Previously, bleomycin was standard of care, and even now it is a standard of care, but it is associated with pulmonary toxicity. So there are trials now looking at either escalation of treatment or de-escalation of treatment. Usually 1 to 3 is considered as negative and 4 and 5 as positive. 4 and 5 definitely you need to change. 1 to 3, especially 1 to 2, is considered as negative and you can de-escalate. 3, again, in some trials have taken it as positive and negative, so it becomes a borderline status. So based on this, you can either escalate or de-escalate treatment, and now this is routinely done, and every PET CT of a Hodgkin lymphoma after 2 cycles, what is called the interim PET CT is reported this way. Vijay?
Yeah. So here is a solid tumor question. A fit patient with cirrhosis is diagnosed with hepatocellular carcinoma. Imaging shows 3 lesions. That is, one is 2 centimeter, another one is 2.5, another is 3 centimeter. What is the best modality of treatment? Next slide. So this is your BCC classification, Barcelona cancer classification. Herein, we know how to approach a patient with hepatocellular carcinoma. So hepatocellular carcinoma, what presents to us is mostly the advanced stage. So that is very clear. You have first, second, and third lines of therapy, which we are not going to discuss now. The most important for us to understand is the early stage and the intermediate stage diseases. So this can be either very early stage, or an intermediate stage. So each one has a definite criteria to be called in that category. So a single nodule, which is less than 2 centimeters, with child A and ECOG 0 being criteria for all these stage very early and intermediate stage patients. So a single nodule which is less than 2 centimeter, or a single or less than 3 nodules which is less than or equal to 3 centimeter, or multiple nodules. So herein we have 3 nodules. So exactly it can be called as less than or equal to 3 nodules can be seen, and all are less than or equal to 3 centimeters. If the patient has had an optimal surgical candidate, then resection was the treatment. If not, you see the eligibility for transplant. If they are eligible, then transplant becomes. So this happens in this hierarchy. You see the eligibility for surgery. If yes, do surgery, that is resection. If not, see the eligibility for transplant. If yes, do transplant. If both are ineligible, either surgery or transplant, if both are not possible, then you go on to do ablation. If ablation is also not possible, then you would go on to do chemoembolization. So this hierarchy is mainly used for this early stage tumors. Other stages are easy for us to remember. So the very clear question is going to be only in this early stage. So 3 criteria. If each criteria gets no, the next one comes in here. Surgery followed by transplant followed by ablation. Next question. So resection for an early stage, if they have a very optimal one, and if early stage liver transplant is also an option, wherein we have defined criteria like Milan's criteria, UCNS criteria, and so much. The used criteria is Milan, wherein it should be either a single nodule less than 5 centimeter, 2 to 3 nodules less than or equal to 3 centimeter, with no major vascular invasion and no extrahepatic disease. Basically, you have a disease which is inside the liver, which is single, which is small, or there are 2 or 3, which is again very small. So in these criteria, if they fit, you can do a liver transplant. If not, then you do ablation with an RFA. So the next question again, this is more like a link to your lymphoma again. So not associated with HCVS. So viral associated lymphomas are multiple. Like EBV was the most commonly asked question. Now here we have a question which is pertaining to your HCV, which for us, we know that HCV related marginal zone lymphoma is very common with your splenic marginal zone lymphoma. So splenic marginal zone lymphoma is actually a rare entity, but it is usually associated with either hepatitis C or Kaposi sarcoma associated hepatitis. And very rarely, treatment can cause a regression of this lymphoma. So treatment of hepatitis C can cause regression of lymphoma. This is one entity. The other one, porphyria cutanea tarda, which we know is because of deficiency of this particular enzyme in the liver, has a very strong association with HCV infection. But on the other hand, HCV patients having such a scenario is actually rare. So there are some other factors which is yet unidentified, probably predisposing such HCV affected patients to develop this porphyria cutanea tarda. So eradication of the virus has actually cured this PCT also. So that is the take home point here. though we have a longer duration of hepatitis C infection to the development of your PCT, still an acute treatment of HCV can result in a recovery from this porphyria cutanea tarda. And the most other, which has actually multiple studies showing association, is your lichen planus. So these are very factual data here. There are so the accept answer is Hodgkin's lymphoma. So lichen planus, marginal zone lymphoma, and porphyria cutanea tarda are associated with your HCV infection. True about men1. So every other NEET is going to have a question from men syndrome. Men syndrome, if we have to remember in and out, men1 and men2. 2 has again 2A and 2B. This picture will basically try to put in all the tumors which are associated with this men syndrome. Men1, remember 3 Ps which we have already seen, that is pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. Pancreatic tumors, more commonly your pancreatic neuroendocrine tumors like insulinoma, gastrinoma, and so on. In men2 syndromes, men2 is very commonly associated with medullary thyroid carcinoma and your pheochromocytoma. So these two are common for both men2A and 2B, wherein this parathyroid hyperplasia is more seen in your men2A, whereas marfanoid arbutus and mucosal neuromas in men2B. Next slide. So men1, you remember 3 Ps. Men2, there are 2 Ps, your pheochromocytoma and medullary thyroid along with your parathyroid. Men2B, your pheochromocytoma with all your M's, that your medullary thyroid, marfanoid, and your mucosal neuromas. Men1 is men1 gene, whereas men2 is the RET oncogene. So the RET is an oncogene, whereas men1 is basically a tumor suppressor gene. So it has to get 2 hits for it to get affected so that the disease gets expressed. So it classically comes under your Knudsen's 2-hit hypothesis. Next.
Yeah. I think to conclude, we had nearly probably 10 questions. So that is from oncology. So though being minority of the questions, you know that these are most common malignant like Hodgkin's and AML, and men is always asked in the exam because it's always confusing. But a simple topic, if well understood, these 10 questions can actually still make a big difference in the scoring and actually in your results. So though you might feel that oncology is something that is probably difficult, but there are these certain topics which can be brushed up well, and QRP sessions are there to help for that. That is from us. All the best for your results and hope to see you on the other side. Thank you.
Thank you. Close.
Yeah, close. Thank you.